Hi, it's Dr. Centeno, and thank you for joining me today. You've got the power. Going to be talking about some interesting things. Basically, the release of the new CCI 101 book. It's the second edition. That's been out now for a couple of years. So we'll be going through that, and then, as usual, we'll go from there to some Q&A and questions, because really the heart and soul of this particular broadcast, YouTube and Facebook channel, is trying to make sure that patients get their questions answered about all things interventional orthobiologics, now with a heavy emphasis on CCI and craniocervical instability. So again, going to be going over that book. Apologize for the mess behind me. Our house is being remodeled, so they got stuff all over the place, and so things are a little bit discombobulated, so I apologize, but it's is what it is. If you live through a renovation, you know you're living constantly in the middle of dust and things being done, and some things get done and some things aren't done yet, and et cetera, so I apologize for that. So let's see, CCI 101. Let me go and share my screen here. So I wrote this book a number of years. Let's see here, entire screen. There we go. Okay, so CCI 101 I wrote a number of years ago to try and give people a perspective of craniocervical instability that was more non-surgical. Really the only perspectives that I found about CCI online were very surgically oriented. Or on the other side of that equation, we had some low-level, not real sophisticated injection work that was being done, but no one tried to marry those two things together to have patients understand what CCI was, what the treatment options were, whether they be conservative or injection-based or surgery. So I put out CCI 101. This is now the second edition. You can see the new cover art here. That's courtesy of ChatGPT. It took a while to come up with that one, but if you recognize that image, you realize that that is Atlas holding up the world. So in Greek mythology, Atlas's job is to hold up the world, and that's how C1 got its name. Atlas holds up your head or your skull being the world. So that's how Atlas got its name, the bone. And I asked ChatGPT to try to do this in lots of different themes. This one was more Van Gogh-esque. And I thought I did a pretty good job. Came up with a really nice image that was representative. So you might ask yourself, why a second edition? Second edition really came out of trying to train the AI model. And just to give you an update on the AI model, it's going quite well. The developer has been working with me this week on hooking up the API, trying to figure out how to do that and get that online. So hopefully that's only just a few weeks out. I know it's taken longer than I expected, but the model is done. What's not done is making sure that that can live on a website and that it can be accessed by patients. So in order to do that, I found myself updating these post-PICL instructions, because as I fed the book and these instructions that we give our patients into the model and started asking the model questions, the model was bonking on a few items simply because I hadn't really written about it. Realized that this ChatGPT 4 AI model reads all of my stuff in real time and then only uses these documents to answer patient questions, which is fantastic for a patient, right? You don't have to read all of this stuff to get a question answered. But if it's not in the documents, it's not going to give you the right answers. So as I asked random questions to the model, I realized that we had some holes that needed to be plugged. And so these are the new post-PICL instructions and information. So if you come in for a PICL now, these are the ones you're going to get. These are super extensive here, everything from before your procedure, the day of your procedure, after your procedure, you name it, it's in here. Longer term after the procedure. Very, very thorough instructions around a procedure. And then as I did that, I realized that there were holes in the book as well. So I was also feeding in the first edition book and realizing pretty quickly that we had some holes. And so in plugging those holes, that then led to the second edition of the CCI 101 book. Now, if you want to get the new edition of the CCI 101 book, just go to the link that's in the description here for this YouTube video, and you'll be able to go to the bottom of that page, enter in your information, and it will give you the CCI 101 second edition PDF for free. There's no charges on this. We are printing out some of these as well so that people can have a hard copy when they come into the office. But I really like the web-based versions of these because at the end of the day, the web-based versions are easy for me to update. So anyway, goes through symptoms. You can see I'm just sort of scrolling through the second edition here. The basic anatomy. Not much has changed there. I go through the basic anatomy of the craniocervical junction in the book through simple diagrams like this, and then go through all of the different ligaments that get treated, both from the front and the ones you can treat from the back. Then start getting into more lifelike images and talk about where, in this case, many joints refer in the head, structure of the C1, C2 joint, and how that's unique. All of the muscles up there, both in the front and the back, the strap muscles, the sternocleidomastoid, all the muscles and nerves at the back of the head, the nerves that come out the front there, etc. So quite a bit of information here in this book. The update is DMX and how, in general, if instability is present, DMX is the most common imaging to that. Common let you know that the new book's available. You can go online. The link is in the description there. Go to the end of that page, just put in your information, and you can get and download the new book. So lots of stuff here in the book. Goes through the PICL procedure, what's done, post-op, pre-op, exercises, other types of surgeries, treatments, etc. Tethered cord, Eagle syndrome, it's all in there. So let me go to some questions here. We have a lot of questions as usual, and I'll stop my sharing. And again, apologize for the house being ripped up a little bit here. Ryan, how would you decide whether to use BMAC or PRP for injecting issues other than CCI? Yeah, Ryan, a lot of that really just depends on what it is we're treating. So let me give you some examples. So for instance, PRP works just fine in moderate and mild knee osteoarthritis. By the time you get to severe knee osteoarthritis, in our experience, bone marrow concentrate works much, much better. Or if we're talking about a rotator cuff or ACL tear, tendon or ligament tear, if we've got a partial rotator cuff or ACL ligament tear, PRP works well. If you've got a more complete non-retracted tear, then that's more bone marrow. So that hopefully gives you some idea of what's going on there. It says in the paperwork, an antigram steroid is used when performing occipital nerve height resection. Can you put this in layman terms, how much steroid is used so I can understand better, please? Yeah, so Rishi, the difference, probably the easiest way to conceptualize the difference is if the height of a matchbook is a nanogram, then the height of the Empire State Building is a milligram. Now, almost all steroids that are used in medicine are milligram dose, the Empire State Building height. Not because that makes any scientific sense, because it's always just been done that way. And the problem is when you use the much, much higher dose milligram Empire State version, you end up getting a lot more side effects and complications. You kill the local cells. Having said that, your body uses corticosteroids on a day-to-day basis. It uses the milligram variety. So we use the milligram variety. That's the height of the matchbook. So you get anti-inflammatory effects without the downside side effects of killing local cells. Andy, since the MCL has good blood supply compared to other ligaments, how many prolotherapy treatments does it take to resolve moderate MCL laxity? You know, MCL is one that responds really well to prolotherapy, one or two at most. I can give you some personal experience there. I had an LCL sprain. It was causing some instability in my right knee. I was starting to get some pinching of that lateral meniscus because of that instability. Had a prolotherapy treatment simply because I didn't feel like getting blood drawn that day for a PRP treatment. And ultimately, the prolotherapy, took a single prolotherapy treatment. I may get a second one here. It's about 90% improved at around 4 weeks out. And so I'll probably in the next 2 weeks or so get it checked using a varus valgus stress ultrasound in the office by one of my colleagues. If it still looks a little loose, we'll probably hit it again. I would say that those instability episodes where I was getting lateral meniscus pinching and subsequently pain with that are down by about 90-95% right now. So I might get a second one, but that gives you some idea. Caleb, can fear avoidance of movement cause a muscle to atrophy over a long period of time? Can this muscle be recovered if the atrophy was due to disuse without any nerve compression damage? That's a good question. I would imagine the answer to that question is yes. I don't know that we've got the research support for that concept, but I would say that if we really were fear avoidance that was causing atrophy, you would see widespread atrophy. Whereas what we tend to see when we talk about muscle atrophy in the neck is very specific multifidus atrophy, which would be more physiologic than psychological, meaning psychological would be, I'm not moving my head or neck, hence all of these muscles are going to atrophy, not just a specific muscle subset. Caleb, I know that you're against the head weights for CCI. Question, since the head weights are attached on forehead, would the suboccipital muscles be getting loaded work to counteract the head weights? Yeah, Caleb, my first sense of head weights was more just patient complaints. So just so you know how I got even sort of notified that head weights were being used was that in doing telemedicines for CCI patients, I would started to hear consistent stories of, oh yeah, I tried the head weights at this clinic, made me much, much worse. Tried the head weights at this clinic, made me much, much worse. So that's the first sense I got that head weights were even an option out there. And since talking to my colleagues that do chiropractic biophysics, you need to realize the head weights are not chiropractic biophysics. Chiropractic biophysics is the curve restoration that's actually been published on quite extensively in the peer-reviewed medical literature, even though it's a chiropractic technique. The head weights are not CBP. They were invented by a single guy. And so far, I've not seen good things. In talking to the CBP experts, they give me all sorts of reasons why they wouldn't use head weights. As far as your specific question, if you have head weights up front, could it load the occipitals? It certainly could load the suboccipital muscles. I think the big question is, can most CCI patients tolerate them? And based on what I've seen, most CCI patients can't tolerate them, nor are they part of what's been published on CBP. Ryan, is it realistic to think that CCI could be a root cause or main issue in causing other issues, such as thoracic pain, lumbar pain, SI joint issues, possibly even shoulder instability, etc.? Or is that simply unrealistic to expect these types of things to get better just by doing the PICL? Yeah, Ryan, we tend to see a couple things. So we know based on the peer-reviewed literature that patients with chronic neck pain get lumbar stabilizers that go offline and can get concomitant chronic back pain caused by the neck issue. Now, does that mean that in all patients, their back pain is caused by CCI? No. I can certainly say that we have a subset of CCI patients where we treat their neck with PICL or something else, whatever the specific type of CCI is they have, and their back, their shoulders, upper back, lower back, SI joints get better. We've got another subset that either has one problem that caused another, and now the second problem has a life of its own, or there's just a second problem that might have something to do with the neck, but it has a life of its own. It needs to be treated independently. So in many patients, we'll also treat their SI joints or their shoulders, etc. So what came first, the chicken or the egg, is often difficult to tell. The questions I ask patients are, for example, if you use a cervical collar, does your back get better? If the answer is yes, then we're not going to treat the back separately. If the answer is no, and there are issues going on in the back that we can see on imaging on an exam, we'll treat the back separately. Rishi, what are your thoughts on chiropractic adjustment called ring dinger? It's insane. Those are my thoughts. It's famous on YouTube. Many people get this done. It's the most ridiculous thing I've seen. Yeah. So I've got chiropractic colleagues who also think the ring dinger is the craziest thing they've ever seen. My guess is so just so people know what the heck it is we're talking about. There's a chiropractic group or a single guy, I don't know which it is, on YouTube where they use some sort of strap. They put the strap behind the head, and then they pull very, very forcefully. I mean, the entire patient jumps as they pull on the head. And the concern, obviously, is you're going to get a certain percentage of people that get pretty substantial neck injuries from using that kind of high force, very non-specific strap-based adjustment technique. The other is that I wouldn't doubt that you could cause craniocervical instability in some patients that way. So I don't at all recommend you get a ring dinger adjustment. You may want to go look up ring dinger on YouTube. They're certainly fun videos to watch, or painful, depending on your perspective. So I'd encourage you to go look at it, but no, I don't think it's a good idea. Kathy, is Proly regulated in the U.S.? My son's physiatrist started using 0.25% polydocanol based off a published study on EDS. He's getting excellent tightening of his ligaments and only 2 to 4 treatments now. How is Proly regulated? Well, Proly is practice of medicine. The stuff that you inject, so that's regulated state by state. The stuff that you inject would be presumably FDA regulated drugs. In this case, this is a drug that's used for venous sclerosis. So if you've got varicose veins, for example. Most EDS patients respond well to just good old-fashioned dextrose prolotherapy. I don't think you need to use stronger solutions there, like the sclerosing agent that you wrote about. So it's not surprising that your son might be getting good results with a sclerosing agent. He'd probably get good results with just plain old 12.5% dextrose, which also works very, very well in Prolo patients. Hopefully my voice isn't still cutting in and out. Let's see if someone else noticed that. I don't see anyone else talking about it. So hopefully that resolved. In a different location, so it's possible the internet connection here may not be as strong as my usual broadcast location. So let me know if that's still happening. I think the person that normally watches these and checks for quality issues like that is having some problems with their, okay, voice is good now. Thank you, Ryder. Lindsay, can a torn rotator cuff make CCI worse? I just found that I have a tear by ultrasound. I'm being told my ortho surgeon and radiologist that they can now see that via ultrasound. All the pain I have is on with the suspected tear. Lindsay, we certainly see interactions between what's going on in the shoulder and what's going on in the neck. We can see the CCI cause, for example, more stress on the shoulder rotator cuff. We can see things like scoliosis, which can bring one shoulder forward, where the patient hangs on those rotator cuff tendons. We can see things like AC joint laxity cause rotator cuff issues, which can then not help what's going on in the upper neck. So there's definitely a connection between the two. Do I think a torn rotator cuff is going to make CCI worse? Probably not, but it's probably not going to help. So the best thing to do would be to get the rotator cuff tear treated at the same time as the CCI. We do that all the time with patients. And unless it's a massive tear, the 2024 way to treat that would be ultrasound guided, either PRP or bone marrow concentrate injection into and around that tear. Massive tears where you've got a huge tear and a retraction and there's no connection anymore would need to be treated surgically. Marcia, hello, Dr. Centeno. I asked Eric after PICL number 3 on January 2nd. It was okay to get a CT angiogram scan with IDA 1 week later. Never got an answer. Went through with the test. Is that okay? Yeah, I think that's fine. I don't think it will really impact PICL in any substantial way. So yeah, that was fine. We did have a switch, so that's important to know. We switched from Eric being my assistant to Ryder. So your contact now is Ryder, R-Y-D-E-R, in my office. So that may have been part of that change there. So I apologize. John, but again, if for whatever reason you can't reach my assistant, don't hesitate to reach out to me. I answer probably about a dozen patient emails a day directly. So obviously try to go through my assistant if it's something simple, but if you can't get an answer there, feel free to reach out to me because, my job is to act as a backstop as well. John, hi, Kathy. My sports medicine mixes the dextrose with small amounts of scarring agent. I agree that it works as well as PRP, saves a lot of money. Reality, money always plays a huge role. I think that's for Kathy. So yeah, mixing a sclerostin in can add more punch. Isn't usually needed, but it can certainly add more punch to Prolo. And when referring to CCI in your new book, is that just for instability at 0-1, or does it include the entire craniocervical junction? No, yeah, all types of instability. So upper cervical spine, based on how we classify it, is 0-1, 1-2, 2-3. Atlantoaxial being C1, C2, C2-3 still being part of the upper cervical sclerotome, and embryologically still being part of what your brain considers your head. So your head unit, according to your brain, goes down to C2-3. So that's why it includes everything from the skull down to 3. Marcia, would a CT angio, when Atlas is out, provided with different information that you wouldn't already have using MRI and DMX? Yeah, not really. I mean, you have to, the biggest problem with the CT scan is it's an immense amount of radiation, about 100 chest x-rays worth. So we normally don't order CT scans unless it's going to really change the treatment algorithm. So even if we see unilateral severe internal jugular vein stenosis, not going to change the treatment plan in a CCI patient. So always happy to look at more data, but it's usually not going to change the game plan. Ryan, I got PRP in the neck for arthritis from C2 to upper T-spine in December. Haven't known much difference in spinal pain. We didn't treat the CCI while I was there. I'm just wondering if that means spinal pain is coming from CCI, or if I should try this area again, possibly VMAC. Yeah, Ryan, I need to know a little more, but if you have pain coming from 1-2 or 0-1, then treating from 2 down isn't going to help. So I would say if I had to make a bet based on what it is you're telling me, all things being equal, that generally means that probably didn't get the right spot. Kimmy, DMX shows C2 axis spinal rotation at 23 degrees, 22 degrees left. It says normal is less than 10. I don't remember you mentioning this measurement at last slide. Was that number you take into consideration with instability or something most people have? Yeah, the biggest problem, Kimmy, with upper cervical rotation is it's common in scoliosis patients. It's a natural consequence of having scoliosis. And since a high proportion of my patients with CCI have scoliosis, it isn't a meaningful number for me. Now, it may be very meaningful if you're doing upper cervical manipulation. It tells you the direction you have to go to get it back to normal. It tells you how far out things are. But from an instability standpoint, it's kind of meaningless because it's very common in anyone with a side bend in their spine and even mild scoliosis. So it doesn't tell me a lot. We also don't have any normal measurements there to know what would represent instability like we do with overhang measurements. So like I said, it's always good to get more information rather than less. I'm happy to look at all information. But usually when we see that, it could be due to either instability or just common scoliosis. Ian, you've mentioned craniocervical syndrome as a diagnosis for some rather than CCI, craniocervical instability. What would be the route to diagnosing CCS and the typical treatment? Yeah, Ian, the big difference and the only difference is craniocervical syndrome doesn't have much instability. Craniocervical instability is about things moving too much. But they both have the same base problem, that structures in the upper neck are getting irritated or damaged, which is what's causing the symptoms. So in both of those cases, we're treating the same structures, C0, C1 facet, 1-2 facet, C2, 3 facet, greater occipital nerve, third occipital nerve, lesser occipital nerve, hydrodissecting the superficial cervical plexus, underneath the sternocleidomastoid, all of that stuff. Those two things are the same in CCI and CCS treatment. The only difference is in CCI treatment, we're also treating those specific ligaments that are damaged. Regenetics been advanced by Harry Winston. What's the information gathered for the new book? Changed anything about the procedure itself? No, it's more just updating the new book to what's happening in 2024 with the procedure and CCI in general. So no, didn't really go the other way. But like I said, as I created this AI model and started to try to break the AI model, what I was able to do is to find that there were things I had thought I had talked about in the book or in the instruction sheet, but never really got around to putting down on paper. So I would say that the second edition book is just a more complete version of the whole story as I would see it, and then updated to 2024. Listen, when you write a book the first time, you think you put everything possible in there. And then obviously it's great to have these AI models because rather than me trying to look through 100 pages, God, did I talk about this? Did I talk about that? The AI model can instantly tell me whether it's in there or not. Mercia, if the left IJV is greatly compressed, does it follow the vagus nerve, 12th cranial nerve, and carotid sheath were also compressed? Yeah, but again, a little bit meaningless, meaning that IJV compression is common in normal individuals. So just so you have an example, if we're talking about severe unilateral IJV compression, that's present in 1 out of 4 normal individuals with no symptoms at all. If we're talking about moderate bilateral, that's present in about 1 out of 3 normal individuals. Severe bilateral, present in 1 out of 5 normal individuals. So it doesn't really change what it is we're doing with CCI. We still need to treat the instability. Now, is it possible that in the long run, if someone continues to, let's say, have 12th cranial nerve issues, problems in their tongue, and we've not been able to fix that by stabilizing the upper neck, we've got good information, the upper neck stabilized, meaning their DMX went to normal, then it's possible that person might need to be decompressed. But if you do it the other way, you're going to screw that person up. If you decompress them first, then you make the neck more unstable, and you may never get on top of treating the CCI. You do it in the way we just talked about. You treat the CCI first to get the stability, and then if you still need to decompress, which is rare, but let's say you might still need to, then at least you left that person stable and added a little bit of instability when you cut the ligament. Great, guys. Thank you for letting me know. Brendan, Dr. Centeno, using your video identifying fatty muscle infiltration, I found out what looks to be some in 2-3. Yeah, so that is a very good thing to look at. If you haven't watched that video, I'd go back and watch it. It's super easy to identify, even for someone that doesn't look at MRIs all day, that fatty atrophy is there. The good news is there are publications on that fatty atrophy. Now, I can use it clinically, but sometimes patients might want to use it if you've got a doctor's like, there's nothing wrong with you, show them the fatty atrophy. Show them the papers and the research on fatty atrophy that's not normal. So hopefully that gives you some patient empowerment to know you're not crazy, right? Yeah, there's something abnormal on my MRI that wasn't read out, and the research says it's abnormal. Marcia, I'm not sure if I'm saying your name right, so I apologize if I'm not. As the atlas is stabilized, AOs plus PICL, does it mean that it goes out less, and is it happens less frequency, eventually stays in place? Yeah, so that's the goal. But realize, as I always say, there's, remember, 2 components to stability, right? You've got ligament stability, you've got muscle stability. So the first that I can do is to get the ligament stability as good as we can get it. And then you've got to build those muscles to get that mid-range stability better. But yes, that's the goal. So for example, someone seeing an AO provider will generally heal or hear as they're staying in longer. So I just heard that from several patients this week. They went from going out once a week, and now it's been months since they've been out, that kind of thing. Brendan, Dr. Centeno, my primary care is telling me that fatty infiltration I found in C3 isn't there because multifidus muscle doesn't exist at this level. Yeah, I would have them read the papers by Elliott. So you may want to pull some of those papers. I think I talk about them in that video. And you can, it's interesting. James Elliott's probably the world's biggest expert on this at Northwestern. And if you look at Jim's stuff, he calls it multifidus. It can be called by other names as well. You can call the deep segmental muscles there by different names too. But it serves the same function as multifidus. So even in the cervical literature, they're generally calling that muscle multifidus. Does it really make a difference? No, it's deep segmental atrophy. That segmental stabilizer, that its job is to stabilize the upper cervical spine. So I'd pull some of those papers by Elliott et al. And send those papers. It's been advanced by Sherry Scott. Is it a problem for PICL procedure that I had an IV treatment of amniotic stem cells 6 months ago? It was the only stem cell treatment close enough for me to get to, but it didn't help, and it actually made me ill for a week. Yeah, so that was a scam. Sorry that you got scammed, but you got scammed. If you paid money for that, I would contact your attorney, state attorney general. You can probably get all of your money back. And if you need me to testify for you for free on that case on behalf of your state attorney general, I would do that in a heartbeat. because you got no stem cells, you got dead amniotic tissue. The fact that someone called it stem cells in 2024 is a complete scam, and it made you ill because it's allogeneic tissue and your body reacted to it. And that's gone. We've seen patients go as far as needing dialysis and getting frank graft versus host disease from some of these treatments. So you got scammed. You should get your money back. I would report that clinic to your state attorney general, have your state attorney general reach out to me at my email address, and I'd be happy to educate them about why you got scammed and why you deserve all of your money back there. Kathy, agree with you on the sclerosant, but I was taking 4-6 treatments to fully heal the lax ligaments using dextrose. Sure, Kathy. Listen, if it can speed the treatment, I think that's great. In general, don't really see a need for it in the patients we treat. Also realize that prolotherapy tends to work based on two things: what you inject and where you inject. So if you're using blind prolo, one of the reasons why blind prolo takes more treatments, because we don't usually treat 4 to 6 prolotherapy treatments in EDS patients, is because you're not getting specifically into those ligaments like you can with an experienced ultrasound guided practitioner. So that's usually why you're seeing 4 to 6 treatments with dextrose prolotherapy, is most of that prolotherapy is still done blind versus guided specifically into that ligament tissue. At least that's been my experience, because there are very few things other than perhaps SI joint instability in women where we're doing 4 to 6 prolo treatments to get stability, even in EDS patients, just using hypertonic dextrose. And any thoughts on stellate ganglion block for long COVID and how it could affect CCI? Yeah, stellate ganglion block can be very helpful. The problem is it's a super invasive procedure, more invasive than PICL. So stellate ganglion block is a procedure where there's a substantial risk of death or the patient coding. Now, obviously, if the doctor is prepared for the patient to code, then it's unlikely the patient's going to die, but it's a big deal, right? The patient's can't breathe, heart stops, etc. You've got to resuscitate that patient. So just realize that while stellate ganglion block can be very, very helpful in sympathetic overdrive syndromes like severe PTSD, and it was first developed for use in veterans, it is a big deal treatment where you have to have the proper resuscitation equipment right here, ready to go at a moment's notice if you run into problems. So I would be very, very cautious about getting a routine stellate ganglion block these days, because it's more invasive than PICL and more invasive than pretty much almost any of the injections that are done in and around the spine, meaning that while we have a crash cart always available in the room where we're doing spinal injections, especially upper cervical spine, we don't have one sitting right here, like right here, so that you can resuscitate the patient within seconds of that stuff going in the wrong spot with a stellate ganglion block. So just be very, very careful with that. Ian, posterior PRP 8 weeks ago in the UK. I have no crunching, grinding in the area where the injection replaced in the cervical spine. Is anything good or bad? Also, is the 8 weeks long enough to assume it's not going to help? Feel no improvement thus far. Yeah, usually for posterior injections, 8 weeks is enough. So I wouldn't be that concerned, or I wouldn't be thinking, or I'd be thinking, I'm sorry, I was just trying to make sure I wasn't getting an email or a text about this broadcast. So anyway, 8 weeks should be enough time for you to see results in general. Now, some patients might take 12 weeks or so, but usually we're in the 6 to 8 week range after posterior injections. So it probably means that posterior injections aren't going to be the thing for you. Is it possible you still may respond? Yes, it's possible, but most patients would have responded by that time frame. Marcia, what is your opinion on hyperbaric chamber therapy sessions to help with nerves regeneration before or after CCJ eventually gets stabilized? I don't think it could hurt. I don't think we have any data that it really does that, especially in CCI patients. But as I always tell patients, I don't think it'll hurt. So if money's no object and it's something you want to try, that is A-okay with me. Levon, hi, Dr. C. How can you know whether vagus nerve is damaged and whether this damage actually causes symptoms? If it's not mistaken, there's no way to tell just by looking at an ultrasound. Yeah, Levon, you're right. I mean, I actually did a review of this not too long ago when we spent some time looking at vagus nerves under ultrasound. Listen, we have clinics out there that are offering all sorts of diagnostic tests that have little validity and aren't really changing anyone's treatment plan. As physicians, we are taught that we shouldn't order a diagnostic test unless that diagnostic test is going to change the treatment plan. And that makes sense, right? You don't want to expose the patient to it. You don't want to bill the patient for it or bill the patient's insurance company for diagnostic tests that aren't going to really change or move the needle on what it is you're supposed to do with that patient. Having said that, we have certain clinics out there operating in the CCI space that have chosen to monetize the diagnostic testing routines that have little validity, and this is one of them, meaning I did a full literature review on this. We have little reason to believe that you can diagnose a vagus nerve problem under ultrasound and that problem is related to symptoms in CCI. And yet we've got clinics charging a lot of money for these. And we know that even if we do see something that someone thinks could be causing symptoms, but we really don't know that, that's going to change the treatment plan. So really all we're doing there is monetizing the tests to earn income rather than using a diagnostic test for the purpose that it's supposed to have. Again, as a doctor, you're not supposed to order a diagnostic test unless it's going to move the needle or has a significant chance of changing the treatment plan. Regenix been advanced by Jerry. Would a DMX that is a year and a half old be acceptable to submit? Yeah, that should be fine, Jerry. Unlikely that things have changed very much in that year and a half, so I think that's generally fine. Kimmy, is visual vertigo a common symptom you see in patients? Vertigo, dizziness, spells with too much busy stimuli or focusing on something close to main focus. Yeah, I wouldn't really call it visual vertigo, but usually what that represents is a problem with smooth pursuit. So I'll give you an example. First, what is smooth pursuit? So see this little can, right? As the can goes across my visual field, my eyes contract the can. That's called smooth pursuit. Now, why do we have that ability? There's a lot of neurologic mechanisms involved there. We have that ability, if you think about it. Let's say it's 30,000 years ago, you've got to kill dinner. You got to throw a spear at dinner, and dinner is going left to right across your visual field. Let's say a deer. You've got to be able to track that object with accuracy through space. And as you track it with your eyes, your neck is going to move at some point. So you have to be able to coordinate your eyes and your neck. Hence, we know that there are reflexes that coordinate upper neck motion and position sense with visual tracking. And it's that smooth pursuit tracking that gets affected when you get bad information from the upper neck. So a great example of how that can impact people is walking down a grocery store aisle, right? What we don't realize is as we walk down a grocery store aisle, it's designed to catch your attention, right? Companies pay top dollar for the space that's right at your eye level, and they pay nothing or very little money for the bottom shelf. Hence, all of those boxes are designed to draw your attention, to look at this, look at that, look at this. And as you do that, if you've got upper neck problems, you can't coordinate that motion correctly, and it can cause all sorts of problems: dizziness, imbalance, vertigo, nausea, etc. Because you can't coordinate that motion with your head and neck motion that goes with it as you look at all of these things. So it's a very common thing in CCI patients, a very common thing that we see in patients with upper cervical problems. Edwin, for REGENXSD, the idea when starting with prolotherapy is to turn on cell signaling for repair healing. I'm curious how did you guys come up with that? The idea was yeah. So Edwin, if you look at the problem in chronic conditions, is that at some point they tip from acute inflammation into chronic inflammation, and those are two different animals. So let's say you're playing basketball, right? You go up, do a layup, you come down, you twist your ankle. You get one bite at that healing apple, and that first bite is acute inflammation. That acute inflammatory process heals a certain amount of stuff, but then it's done. And if it's done and you still have a problem and that joint is left unstable, it moves into chronic inflammation. A completely different concept, even though both are called inflammation. Acute inflammation over here, chronic inflammation over there. So the goal with that process, and we actually have a US patent on that, is to cause a brief inflammatory response to switch the area to acute inflammation. And then by approximately day 3, as you start to get cellular recruitment to the area, to add those cells. So that's the general concept behind it. Gina, what is your stance on chin tucks, both for general population and CCI patients? Yeah, Gina, I think that if you're doing chin tuck work, that's deep neck flexors, or the goal is to activate the deep neck flexors, longus colli, longus capitis. Now, there's a way you can do that using a blood pressure cuff back here for biofeedback. That was invented, that process or procedure was invented by Gwen Jull in Australia. There are physical therapists out there who can help you with deep neck flexor work, who use that biofeedback blood pressure cuff. And the goal there is to do very small movements where you're flattening out your lordosis and using these deep muscles. So I think if you're doing it under that kind of supervision, I think it's going to be quite helpful. But just doing this, probably not going to get the same effect. Marcia, when I woke up for PSL number 3 and for about a couple of hours later that day, I experienced the best natural breathing in my life. What is the good guess as to why that would be? Yeah, probably because you were in that acute inflammatory phase would be my guess, and there was stability. Now, could it also be related to a vagus nerve hydrodissection? It could, because the phrenic nerve is close to there. So, and the phrenic nerve deals with breathing. So lots of different possible explanations, one being the mechanical sleep apnea component, additional stability due to acute inflammation. So it could be a couple different components. Levon, if misaligned atlas is determined to cause a myriad of symptoms which hamper life quality, does that warrant PICL, assuming no other indications PICL are present? Yeah, so that's a good question. Right now, the indication for PICL is the type of instability that generally would warrant some sort of upper cervical fusion surgery. Now, we have decided to take some people who are short of that, but we're almost certain have instability and are miserable and disabled. Now, as we're getting towards thousands of procedures, we're now at around probably 1,400 procedures. But as we're getting towards thousands of procedures, and then we have a good sense of what the risk matrix looks like, might we bleed over into patients like this, who just have a misaligned atlas, they're not fusion candidates? And the answer is yes. I think we will get there where we can treat that patient population, being able to say, hey, the risks of this are very low. Here's that data. And it makes sense to treat this. You're not fully disabled by it, but you do have to continue to get chiropractic adjustments. And there's no other reason for this to happen other than small amounts of instability, because remember, that can happen due to scoliosis. We've talked about that. And so that may be opened up to more of those patients. So it's a good question. Bo, when I lay down, my nerves seem to start getting irritated. I feel a lot of pain at the top of my head. And a procaine injection at the top of my head to help it. Can dry needling help with that? Yeah, so that's more the nerves back here. So greater occipital nerve, third occipital nerve, lesser occipital nerve, all of those. So normally that's platelet lysate hydrodissection. Dry needling usually isn't going to help that. Because the problem is irritation of the nerve. Now, it certainly may be possible to do dry needling of the suboccipital muscles, not the tendons, but the muscles. And the muscles may relax enough to cause reduced irritation of the nerve. But if the nerve is so sensitive that just laying on it is causing the issue, you're now into the types of things where you need nerve-based treatment. Mohan. Can trapezius muscle weakness in the upper thoracic area cause trapezius in the upper neck to get inhibited? My PT has given me some scapular exercises and neck exercises helping my heavy head. Can trap muscle weakness in the upper? I don't think so, meaning that I think what you're asking is if you've got scapular weakness, so mid to lower trap weakness, can that cause the upper trap to get inhibited? Listen, it's certainly possible to see weak muscles, and you may have a weak trapezius in general. So if you can do exercises that will reduce your heavy head feeling, I think that's a net positive as long as it's not ramping up or irritating other things. So I think that's the best answer to your question. Brendan, Dr. Centeno, do you find individuals with their lumbar muscles offline present as someone with the anterior pelvic tilt? Usually those two things aren't related, no. And I'm going to start going through these a little quicker because we're coming to the end of the hour, and I do have a pretty packed afternoon as far as meetings go. Michael, I'll be at your office for likely PICL on Wednesday. I have arthritis crepitus at high C level when I've had stem cell shots in the past 3 times the past 3 years. Then it crepitus for about a year. Do you know why the stem cell makes crepitus for a year? When I got rid of Yeah, so I think we talked about this, Michael. I think you and I did, because I recall this a little bit. Basically, I think what is happening there is you're getting reduced inflammation in the joint. There's still the instability beating up the joint. So at some point, the wear and tear starts to get the better of the repair. So you put that stuff in, repair ramps up, inflammation goes down. At some point, wear and tear gets the better of repair again. And that's due to the instability. So I think that's what's occurring there. Mohan, I have small amounts of fatty atrophy at 2-3 on the left side. When told my original doctor, didn't know and got embarrassed, started acting like a douchebag. Dr. Henson agreed with me, thankfully. Yeah, listen, Mohan, this is highly specialized stuff. So most doctors would have no idea what you're talking about. I've always found that it's not a bad idea to consider just sending some of those papers to your doctor. Those papers were all referenced in that C2-3 atrophy YouTube video I have. Listen, that might not help them right away or how they're treating you, but it may help the next patient who comes down the line because they go, yeah, I read about that. That patient sent me that, and I didn't know it was a thing at the time, but now I know it's a thing. So, it's one of those pay it forward things maybe. Liam, hi, Dr. C. Is BMC and facet joint cap superior to PRP? Also, a C1C facet joint anatomically the same as 0-1 facet joint. 1-2 facet joint is extremely different than the 0-1 facet joint, and that's in the book, by the way. BMC facet capsules could be helpful or more helpful in the joint. The problem is we've seen that a pretty substantial amount of CCI patients will flare pretty badly if we use BMC in the facets. So we do that very selectively for that reason. Caleb, that's so nice of you to offer to testify for sure. Oh yeah. I'm happy to do that. That thing has pissed me off so badly. I've done that for several patients, by the way. I've testified for several attorney generals around the country on that one, just because it's a really bad scam and it's got to stop. And it's only going to stop if patients complain to state attorney generals, and state attorney generals get some street cred by going after the scumbags that are doing it. Daniel, can injections to the muscles help with stability? It's a good question, Daniel. We believe it may help get rid of some of the muscle trigger points there and activate the muscles. We believe it may help those muscles repair. But that question, the only, hold on a quick second, guys. Here. Sorry about that. So the only paper I've ever seen was out of Egypt. They injected PRP into multifidus muscles. They claimed it helped with the multifidus atrophy. That was in the lumbar spine. I haven't seen that replicated at all. Brendan, Dr. Centeno experience, are ligaments able to be tightened and bulked up just as the muscles are able to? I think ligaments get stronger in response to activity for sure. I think we can repair ligaments in general in the right circumstances based on my clinical experience using various injectates. As far as bulking them up and getting them bigger, that's going to take loading on the patient's part. Melissa, is there any progress in getting PICL covered by insurance or Medicare? Melissa, it's covered by 2,000 corporations right now. And that includes big companies, Fortune 500 companies. As far as getting it covered by Medicare, I think you've asked this question before. I don't see that anytime soon. So I don't think we're going to see that before I personally retire even. Levon, if heart rate variability test shows parasympathetic dominance, can that be false? You actually have sympathetic dominance. Sure, that is possible. Caleb, there's an article research published by Dr. Hauser, C12 is totally stabilized by capsule. Yeah, there's no publication in any peer-reviewed journal by Hauser on C1, C2. There, I think you're talking about Hauser and some of the folks that do prolotherapy put out kind of a newsletter more than a journal. It's not a real journal. It's called the Journal of Prolotherapy. I had stuff that was published a long time ago in it. It's not a peer-reviewed journal, and we don't have much information that the 1-2 capsule stabilizes. Hey guys, I do have to get going here. I see I've got a bunch of great questions still here to answer, so I apologize. But unlike other afternoons, this afternoon is totally packed. Let me just double check my schedule to make sure. I'm pretty sure I've got something immediately following. If I don't, I'll stay on here and answer these questions. But let me just double check because I know that this afternoon was insane as far as the schedule is concerned. So let me just see what the deal is here. Yeah, so I do have a 2 o'clock. Okay, guys, well, I apologize. I'm going to have to cut out early here, or not early. I've been here for an hour, but there's some great questions here. I would really encourage you to hold your question till next week. I will be at the Interventional Orthobiologics Foundation conference next week, so I don't know that I will be available, but I will tell you what I will do. I think you guys know my email address. In case you don't, I'm putting it right down here. If someone has a burning question they really want to get answered that can't wait either till next week or the week after that, I'm not quite sure if I'm going to be able to do this next week because of that conference, then feel free to email me. The email address I just put down in the comments goes directly to my personal email inbox at work. So feel free to reach out. But I do have to get going on this next meeting because I've got people waiting on Zoom. So thank you. Thank you so much. We talked today about the new book. Feel free to download it. It's free. I updated it because, again, there were some holes I saw that needed to be filled, so to speak. And hopefully we'll get the AI model up here in the next week or two. You guys have a fantastic weekend, and thank you for all the great questions as usual. Hopefully you learned some stuff.